Good morning, everybody. Thank you for joining. We will get started here in just another minute or two. All right, it is 10 o'clock, so we will get started to make sure we are respectful of everyone's time. Good morning, everybody. Thank you so much for joining us today. My name is Alex Faust, and I am an outreach specialist with the Wisconsin Cancer Collaborative. Today's webinar is the financial toxicity of cancer, causes, effects, and potential solutions. And we are so happy to see so many of you with us today. We think it is our biggest webinar to date, so we are very excited to see you all. And before we get started today, I have just a few housekeeping notes to go over. Firstly, we are delighted to have so many new people joining us today, along with our existing members. For those of you who may not be as familiar, we are the Wisconsin Cancer Collaborative, a coalition comprised of 140 organizations working together to reduce the burden of cancer for everyone in Wisconsin. If you are not yet a member, we would love to have you join. Membership is free, and if you are interested in joining, you can do so at the link on the screen. Secondly, for those who are already members, it is membership renewal time. We did extend the deadline to renew your membership by a little bit, so if you have not done that, we would love to have you renew those. It's very quick and easy to do, and you can do so at the link below. This year, we are asking all members to add just a few new pieces of information to your profile, including the Wisconsin Cancer Plan priorities that you work on, counties you serve, as well as the populations you serve. If you have any questions, feel free to send us a message. Here is the agenda for today's call. Before we hear from Dr. Chino, we're going to have a quick intro to financial toxicity by Alexandria Culweatherer and Amy Johnson, both staff members of the Wisconsin Cancer Collaborative. After their brief introduction, we will then have the presentation by Dr. Chino, followed by time for questions facilitated by our director, Beth Runner. So before we dive in today, we wanted to highlight our issue brief, the financial toxicity of cancer. We're going to be touching a little bit on some of the points made on this, as well as some additional comments by our staff members. So with that, I will hand it over to Alexandria.
Good morning, everybody, and thank you for having me. So firstly, what we're just going to talk about is what is financial toxicity and what does it mean? Next slide, please. So the National Cancer Institute defines financial toxicity as this general term used to describe problems a patient has related to the cost of medical care. So for example, not having health insurance or having a lot of costs for medical care not covered by health insurance can cause financial problems and may lead to debt and bankruptcy. Financial toxicity can also affect a patient's quality of life and access to medical care. And I want to add that cancer can cause severe financial distress for not only patients and survivors, but also their caregivers and families. Next slide, please. And so cancer is one of the most expensive illnesses a person can have. And in 2020, projections estimated that cancer care cost the US $173 billion. And these financial difficulties can last for many years after diagnosis. This burden can be caused by a combination of direct and indirect costs, such as high out-of-pocket expenses, as well as things like transportation, childcare, and other expenses incurred during and after treatment. These costs can create hardships that reduce quality of life, threaten the ability of patients and families to meet basic daily needs, and negatively affect patient outcomes. Next slide, please. And so Dr. Chino is going to talk more in detail about the national landscape, but I wanted to bring up two studies that are Wisconsin specific. We have limited studies measuring financial toxicity in Wisconsin. And so a recent poster presented at the American Society of Preventive Oncology looked at limited sample of 306 cancer survivors included in the Survey of the Health of Wisconsin. They found 7% borrowed money or went into debt as a result of cancer or its treatment, and 6% did not receive needed medical care, tests, or treatment because of the cost-related barriers. Rural survivors were more likely than urban residents to borrow money or go into debt. And the SHOW survey also found greater financial hardship among Black African Americans, Hispanics, younger survivors, and survivors with no insurance. And so while data from SHOW may not accurately represent the scope and impact of financial toxicity on all Wisconsin cancer survivors and their families, it does provide insight on how financial toxicity is a concern among some survivors. Next slide, please. And then another study published in 2020 by the Wisconsin Oncology Network looked at employment issues among Wisconsin cancer survivors. The 111 participants surveyed were mostly white, female, and average 48 years of age, and breast cancer was the diagnosis in more than 2/3 of cases. And this study found that full-time employment decreased from 88% pre-diagnosis to 50% during treatment. However, the good news is a majority reported they returned to work 12 months after their treatment ended, with a small percentage reporting persistent difficulties. Next slide, please. And then I'm going to hand it off to my colleague, Amy Johnson, our policy coordinator, to discuss more of the policy considerations discussed in our issue brief. Thank you.
Thanks, Alexandria. Well, financial toxicity is a broad challenge, and responding to that challenge requires that a cancer patient be savvy on health insurance, employment protections, and for some, disability laws. To start, having health insurance is critically important for cancer prevention, screenings, cancer treatment, and survivorship needs. But having just any type of coverage is not enough. Patients need plans that provide access to services and doctors. Unfortunately, not all plans are required to cover cancer prevention and treatment, and not all providers accept some types of coverage. The issue brief explained Medicare, the Affordable Care Act, and Medicaid. It also went beyond health insurance to discuss employment protections and disability. For those 65 years of age and older, Medicare is a lifeline to insurance. Medicare is the largest source of payment for cancer care and covers half of all cancer survivors. However, the traditional fee-for-service model used by Medicare covers only 83% of all hospital and doctor services. To address that gap, 85% of Medicare beneficiaries purchase supplemental insurance at an additional cost. When successfully combined, Medicare's scope of services offers seniors some protections against the harshness of financial toxicity for their treatments. Not to dismiss the complexity of Medicare itself, but for the other 50% of cancer survivors, the landscape is much harder to navigate. It's in this other 50% where we find the uninsured. The uninsured percent of all Wisconsinites in 2020 was 5.7%. For those with some type of healthcare coverage, over 50% of the residents received health insurance from their employer. The rest are covered through the Affordable Care Act Marketplace, short-term plans, and the Wisconsin Medicaid program. The ACA established a marketplace for residents to purchase individual and family insurance coverage, and those plans must comply with ACA protections and services for things such as cancer screenings. Today, around 200,000 Wisconsin residents have coverage through ACA Marketplace. The other major component in Wisconsin is the Medicaid program itself, which covers children, adults under 65, people with disabilities, some seniors, and pregnant women. Within these categories are separate programs, some with differing income ceilings. More than 1 million Wisconsinites are covered under Medicaid. Next slide. Looking at the workforce, cancer survivors who are of working age face unique challenges and are more likely to be limited in their ability to perform their jobs full-time or at all. Cancer survivors undergoing treatment miss 22.3 more workdays per year than persons without a cancer history. And Alexandria gave a good statistic on how the cancer survivors were able to work or unable to work. Cancer patients who work for employers with 50 or more employees may be eligible for unpaid leave under the Federal and State Family and Medical Leave Act, or FMLA. The federal FMLA allows eligible employees to use up to 12 weeks of unpaid leave per year for family and individual medical related reasons without losing their job or health insurance. The Wisconsin Family and Medical Leave Act allows eligible employees to use up to 2 weeks of job protected unpaid leave per year for medical related reasons. However, employers in Wisconsin with fewer than 50 employees are not required to provide medical leave under the state or federal FMLA. It's important to know this limitation affects a large percentage of Wisconsin's workforce. Cancer survivors who are able to continue working during or after treatment may turn to the Americans with Disability Act, or ADA, in working with their employer to accommodate their health condition. The ADA allows people to continue working or return to work if they're able to perform the essential parts of their job. Survivors who are unable to work may seek assistance from the Social Security Administration under the Social Security Disability Insurance or Supplemental Security Income programs. The Social Security Administration established the compassionate allowances for individuals with severe medical cases, including some forms of cancer, which allows the Social Security Administration to expedite cases quickly. The system obviously is a tangled web, and unfortunately, those who are going through cancer treatments must navigate a very difficult process at a time where they may have the least amount of mental, emotional, financial resources to do so. The link to our financial toxicity issue brief is included in the chat for you to check out. And thank you. I'll turn it over to Alex.
Thank you, Alexandria and Amy. And now I'm going to hand it over to Dr. Chino. And while she gets her slides pulled up, I will give a brief introduction of her. So Dr. Chino is a cancer researcher and assistant attending in radiation oncology at Memorial Sloan Kettering Cancer Center. Her research is focused on the financial toxicity of cancer care, healthcare disparities and access, patient-reported outcomes, shared decision-making, survivorship, and end-of-life care. Her work has been published in JAMA Oncology, Cancer, the American Journal of Managed Care, and the ASCO Education book. Her commentary on healthcare reform and cancer care has been featured in JAMA Oncology, the Los Angeles Times, and The Conversation. Her work has been covered by national news media outlets, including the New York Times, Forbes, and NPR. She graduated medical school and completed residency at Duke School of Medicine as the chief resident. She is currently a director at the Costs of Care Group, a global NGO focused on affordability in healthcare. She has received research support from the Channel Foundation and the Radiation Oncology Institute. She has spoken across the US and internationally on the cost of cancer care. We are so thrilled to have Dr. Chino with us today. And with that, I will hand it over to her.
Thank you so much for that kind introduction and for the invitation to speak today. I am incredibly passionate about this topic. Before I move forward, I just want to make sure everyone can see my slides.
Yes, we can see them.
Awesome. Okay. So the topic I was tasked today to speak about was causes, effects, and possible solutions to financial toxicity. So just kind of diving into it, I have no disclosures. Financial toxicity is really a new name for a growing problem. And this is a phrase that my mentor, Dr. Yusuf Zafar, said in his seminal manuscript in The Oncologist when he popularized the phrase financial toxicity to describe what was actually happening to our patients. When we think about the idea of cost and the burden that it's really pushing onto our patients, I always point to this ASCO opinion survey, which shows that there's actually slightly more people who are worried about the financial burden of cancer care than they are of dying from cancer. And I always, again, take a moment to really think, okay, this is really affecting our patients, our patient families, and it's really something that is a pressing concern. This idea of financial toxicity has trickled all the way up to our highest medical journal. So this was a perspective in the New England Journal of Medicine, positing the idea that we should really be talking about costs as a side effect. So just as we would never allow a discussion to start chemotherapy without reviewing all of the costs related to all of the toxicities, we should think about costs as one of those side effects. This is also trickled down to the lay media, in publications where there's more and more people who are realizing this is a problem for them or their family. And, newspapers like USA Today have even featured stories talking about how costs have become a true and real barrier to receive quality cancer care. And this is where I have to say, well, I haven't been completely honest. I do have a disclosure, not that I have made so much money from financial toxicity, but that I have myself have paid a lot into financial toxicity as an incredible burden. And when my husband was diagnosed with cancer, we had excruciating costs related to his cancer care. And unfortunately, after he died from cancer, those costs followed me for over a decade, and it really cast a shadow over my life. It's the reason why I went into medical school. It's the reason why I'm giving a presentation today about financial toxicity, because I really know how it matters on a personal level. So what is financial toxicity? Covered this slightly already, but just to highlight, the National Cancer Institute really posit, the place of financial toxicity is at the patient. It's not healthcare system cost. It's not system charged cost to the insurance. It's really the costs that make it to the patient. So it's the problem that a patient has related to the cost of their care. And again, patients with cancer are more likely to experience this than others with chronic disease. In my own words, what I say is that, in the United States, even with health insurance, these high costs of care are leaving some vulnerable American families adrift in debt. And then they really have real effects on quality of life and quality of care. So we got here by many ways. Financial toxicity is truly multifactorial, but one of the primary driver is just rising healthcare costs. So we're talking about at a billions of dollars level, how patients are, how society is really paying more for healthcare. So at this point, we're at $3.8 trillion that we're spending on healthcare in the United States circa 2019. The costs per capita have also risen from about $1,000 to over $11,000 per person. Again, spending in 2019 for healthcare. Sadly, what we're realizing is that we're getting more and more expensive drug costs, but the clinical benefit is essentially stagnant. So this was actually a really nice study that was published a couple of years ago. You can see in the blue line is the actual monthly cost of new cancer drugs. And in the yellow line is two different frameworks evaluating their value. And you can see really not rising values related to rising costs. So we have stagnant clinical benefit related to costs. Unfortunately, what we've seen is that even though these costs are rising, incomes are not commensurately rising. Monthly household income has been relatively flat over time since the 70s. And again, just comparing it to the steep rise of costs, you can imagine how things can become rapidly unaffordable. Increased cost sharing is a real problem in the United States today. So that means, for example, that you may have health insurance, but it is just not making your care affordable. So the idea that many people are underinsured in a cancer diagnosis. And what our study published in JAMA Oncology showed is that there were a portion of patients who were really suffering related to their cancer diagnosis. And that for people who had this high, financial distress, they were paying up to a third of their take-home pay, related to healthcare costs. And ultimately, some of these costs were unexpected. It was related, and that drove willingness to pay for cancer care. So we're lowering cancer willingness to pay related to high costs. We know that financial toxicity matters to our patients, and it decreases discrete things like quality of life, satisfaction with care, and actually the quality of cancer care that is received. So if you look at the graphic on the left, you can see what I consider to be the unholy triangle of financial distress, which is all of these things: quality of life, perceived quality of care, and advanced disease are all interrelated, and financial distress is in the mix. So sadly, you cannot pull out one thing or the other, but what we know is that patients who have a lot of financial problems are just, quite frankly, much less likely to rate their quality of life as good, and that financial toxicity is associated with anxiety, fatigue, poor social functioning, poor physical functioning. So we're really, our financial burdens are really coexisting with bad outcomes for our patients. We know that there is decreased satisfaction with care as financial burdens increase. So this was a study looking at correlation of satisfaction scores and financial burden. You can see on the top in the blue is a standard bell curve for people who have low financial burden. So their satisfaction is, on a standard distribution. But for people who have high financial burden, it is really shifted towards the left. So it's shifted towards not satisfied with their health care. And this matters because patients who are not satisfied with their health care, have more problems with trust, and it erodes their ability to actually receive care, to maintain adherence to a treatment plan. We know that ultimately high costs can decrease the quality of care delivered. There's a number of different studies showing this. This is just a study that our group did showing that medication non-adherence related to cost was over a quarter of patients. And that includes 1 in 5 who didn't even fill a prescription related to the costs of their care. And I think terrifyingly, 1 in 20 who skipped, took less, or didn't fill their chemotherapy prescriptions. So again, something that will directly affect the efficacy of their anti-cancer treatment. We know that financial toxicity decreases satisfaction, quality of life, quality of care, but it increases other things, unfortunately only bad things: personal family burden, risk of bankruptcy, and ultimately the risk of death. So again, some research out of our own group showing that there is a large proportion of patients that are making sacrifices in order to afford their care. About 2/3 of our sample had made some sort of sacrifice, including over half who had used their savings in order to afford their cancer treatment, and about a quarter who had gone into debt, who had to borrow money in order to afford their cancer treatment. Sadly, we know that financial toxicity does not affect everyone equally. So there are some patients who are even at a higher risk of a bad outcome related to financial toxicity. And this study I point out quite frequently that shows 1 in 20 Black or Latinx women with a curable cancer actually became housing unstable related to the costs of their cancer treatment. So again, a curable breast cancer, early stage, and just the treatment itself was enough to push them over to being homeless. In the United States, cancer treatment causing homelessness is just untenable. We know that ultimately you have this decreased satisfaction with care, you have decreased quality of life, you have decreased quality of care, you have housing instability. We're increasing the risk of bankruptcy. And so this is the seminal manuscript by Dr. Ramsey out of the Seattle group showing that patients who had a diagnosis of cancer were just much more likely to have to declare bankruptcy. So the true financial catastrophic outcome. So more than 2.5 times more likely to declare bankruptcy. And this matters not just for financial futures, but because it increases the risk of death. So in the follow-up study to the bankruptcy evaluation, Dr. Ramsey showed that, again, for people who had a bankruptcy in the context of a cancer diagnosis, they were almost 80% more likely to die of all causes. So again, a line from costs, quality of life, quality of care, high financial burdens to increased mortality. I want to do a slight segue to just highlight the fact that we're in, unfortunately, still a global pandemic, and the burdens related to a cancer diagnosis and treatment and survivorship are only made worse with the additional economic burdens of COVID-19. So this was a manuscript that was just published last week of a survey we did for AYA survivors. So patients with cancer who are treated before the age of 40, already at risk for financial toxicity, and their negative outcomes related specifically to the pandemic. So about 1 in 5 lost their job or were furloughed. 1 in 5 were not able to make, rent payments. And I think terrifyingly, again, the end outcome of that is that over a third had a medical problem, but really couldn't afford to see a doctor. So financial toxicity is bad. It is even worse now under the negative economic pressures of the pandemic. So where do we go from here? Because I do want to spend the bulk of my talk really talking about potential solutions, because quite frankly, it's a little too depressing to think about only the burdens that some of our patients are facing. And again, I speak to this personally in terms of, we really need to think about, well, how do I actually help patients, in the future so that we can decrease some of these poor outcomes. And I really love this framework, again, by Dr. Zafar, which puts it simply, there are nesting solutions. Financial toxicity is a multifactorial problem. There are multifactorial solutions, from policy to parking. We're talking about anywhere in between systemic, interpersonal, individual frameworks to think about what can drive improving outcomes for our patients. So the first step is just to think about policy guidelines. So on a national level, who can we get together? Who do we need in the room? And what policy guidelines can we think that actually improve outcomes for our patients? So the President's Cancer Panel, does meet every couple of years. Most recently in 2018, they put together this brief looking at value and affordability. And they actually put together some really nice guidelines in terms of how do we get together with all of the key stakeholders? How do we align pricing with their value, which of course we've already mentioned they are not aligned? How do we ensure affordable access? And how do we continue to actually promote innovation, which is again what the United States is so proud of in terms of our ability to develop the next new treatment for cancer. Thinking about national healthcare initiatives, there's really no greater one than the Affordable Care Act. And this policy really did make a difference for cancer patients and cancer survivors, including, for example, eliminating the idea of a lifetime cap, something that, again, I know excruciatingly well from my husband's treatment. Stopping the idea of disallowing insurance, barring insurance for someone with diagnosis of cancer, or this idea of a pre-existing condition. They can't charge you more for that. And guaranteeing treatment for both cancer and clinical trials as a concept. We'll go into a little bit later about the idea that Medicaid itself had a hole for that. But this manuscript published in JCO shows specifically who it helped. So in terms of the primary legislative initiative from the Affordable Care Act, which is Medicaid expansion, you can see that states that expanded Medicaid really did have their new diagnoses of cancer be less uninsured. And regardless of how you feel about Obamacare, regardless of how you feel about healthcare policy, political swings, I think we can all agree that it's better to have health insurance if you have a cancer diagnosis than to be uninsured. And specifically, again, if you look at the blue line, the patients who had the lower income, i.e. patients who are at the biggest risk of healthcare disparities, had the steepest drop in the rate of uninsurance at a cancer diagnosis. Unfortunately, because healthcare policy and politics are so inextricably linked in the United States, what we've seen under the Trump administration has been an erosion of ACA policies, which has directly translated to rising uninsurance for cancer patients and survivors. So this is a small letter that we published in Lancet Oncology last year, specifically tying policy changes and the rates of uninsurance in the population of cancer survivors. And what we found is that there was almost 200,000 in more uninsured cancer survivors after the nadir of the benefits of the ACA. So unfortunately, these policy changes really are translating to people losing their health insurance. And again, I'm not a shill for the ACA. There are major problems with this plan. I wanted to highlight the fact that you know, some of the plans under the Affordable Care Act, so this study specifically evaluated plans that were available on the exchange. They found that although the majority of plans included at least one Commission on Cancer accredited hospital, the minority included in-network coverage for NCI cancer centers. So for people with cancer, particularly rare or aggressive cancers that do want to seek care at NCI cancer centers, they may be paying out of pocket much, much more in out-of-network fees, just related to the fact that just health insurance, although better than no health insurance, just health insurance alone, as opposed to a quality health insurance for your cancer diagnosis, may not be sufficient to make your care affordable. I want to also mention the idea that there is really a role for national advocacy when we think about affordability in healthcare, when we think about financial toxicity. And the Clinical Treatment Act was something that the Trump administration rolled into end of year legislation to actually, you know, say, you know what? Previously, Medicaid was excluded from ACA provisions that required coverage for clinical trials, meaning that someone with Medicaid, so a newly insured patient with Medicaid who has a cancer diagnosis, would not necessarily have coverage for their clinical trial. So what changed though was that they basically said, okay, fine, we'll make this provision rule that Medicaid now needs to cover clinical trials, which was a huge benefit for some of our patients. Again, the ones most at risk, the ones who may, you know, most need clinical trial access. So I think this was, I'll be honest, a quite big win, and I think it directly related to the huge advocacy efforts of ASCO and other national organizations. There are national healthcare initiatives to think about in terms of, for example, on the provider side, how do we actually minimize low value care? How do we improve value in cancer care? If we're ordering tests or treatments that are not proven to have benefit, but that have high costs, we should not be doing those things. And the Choosing Wisely campaign was really designed to try to highlight the low-hanging fruit that we should, you know, be seriously thinking of eliminating because they just provide very little benefit for our patients. There's also de-escalation research. So this idea that, is there ways that we can do more with less? Are there lower doses that we can use for some of our chemotherapy or you know, targeted therapy drugs, immunotherapy drugs, so that we can get the same outcome, but with lower costs, which not just helps the healthcare system with burdens, but also helps patients. And I'll always say, you know, when we think about, you know, our research priorities. How are we showing that the things that we're doing, innovations that really can change cancer treatments, how do we prove that they're actually worth it? Because a lot of these innovations are very expensive. And how do we show that our new fancy treatments really are providing value for our patients? So I always put a plug in the idea that in medicine, we often put the cart before the horse. We often rapidly adopt expensive new treatments, like, for example, minimally invasive surgical techniques. And sometimes we don't do the work to prove that they actually are effective. So I'll point to, again, the New England Journal of Medicine trial, which showed that this more expensive technique of a minimally invasive surgery was actually worse for cancer outcomes. So I spent some time thinking about policy, healthcare systems level, but ultimately we want to help the patient who is in our clinic, who is, having problems related to the costs of their care. So what can we do at the provider and patient level to improve financial toxicity for our patients? I really do like to think about this on a public health framework of primary, secondary, and tertiary prevention. How do we really think about preventing financial toxicity before it even occurs? If it is going to occur, secondary prevention, how do we at least reduce the impact by diagnosing it early so we can start treatment? And then tertiary prevention, how do we, treat it effectively so that it has less lasting effects? So, preventing financial toxicity at the interpersonal level, how do we go about thinking about what we can do on a person-to-person level? And thinking about from both sides of the equation, because anytime there's anytime there's a cancer interaction, there's both patients and providers in the room. And thankfully, something like education, just listening to me blather on for half an hour today is the first step. It's the first step for patients, it's the first step for providers in terms of awareness, knowing that this is a problem and knowing that there are potential solutions. On the patient level, things like optimizing health insurance, so the role of, for example, financial navigators, has been shown to actually, number one, actually improve affordability for patients, obviously most important, but also to help save healthcare systems money. So healthcare systems that invest in financial navigation programs can actually really decrease what they're paying, for charity care or unreimbursed bills. We can think about optimizing financial assistance, so being proactive versus reactive. So trying to actually help people get the financial assistance that they may qualify for before they're already in a hole, or before they're already not showing up for their treatments because they can't afford them. And then how do we think about improving access to healthcare in general? So for example, a lot of people receive their health insurance through their work. And there was some really compelling data presented earlier about the return to work concern. So how do we actually schedule our treatments, think about structuring our healthcare delivery around someone's capacity to work? Because this may mean for them that they be able to keep their health insurance, keep their income, but also keep their family together. Because sometimes a working individual with cancer is not just the breadwinner for their family, they're also the person that is providing health insurance for their family. At the provider level, there's this idea of value-based care. So within ASCO, there's a value framework to think about how do we actually have the difficult conversations about costs and outcomes. How do we think about encouraging high value care, limiting low value care, either through cost-aware prescribing patterns or price transparency? So just the idea, when I found out as a resident that a medication I was prescribing for a symptom of proctitis or irritation of the bowels related to radiation, I prescribed someone Anusol. When the patient told me later that it cost them $400 for a suppository, my mouth just dropped open. And ever since I found that out, I have stopped prescribing Anusol. There is no way. It is not worth $400. So just being aware of what medications can be very expensive for patients can make a huge difference so that patients are not surprised at the time of their pharmacy. And heaven forbid that they don't pay $400 for a suppository. The idea of shared decision-making is so important when we think about financial toxicity. So really sitting with patients and really identifying what their goals of care are and what the true cost of treatment are for them, meaning their time away from work, their out-of-pocket expenses, thinking about how do we best serve our patients, not just from a cancer perspective, but from a whole big picture perspective, with cost being one factor. So diving just a little bit into this, the role of financial counseling can really help patients actually understand their costs better. This is important for me because I had prior research showing that people who had unexpected costs were much less likely to be willing to pay for care. So just the idea of meeting with someone upfront, getting an estimation of their cost, helping them understand their health insurance can be a huge assistance to patients. Again, that value-based care. So the idea of the ASCO value framework is just to facilitate this discussion so that providers and patients have an idea of what the true benefits in terms of clinical benefit, toxicity, including costs, and then making that calculation based on, again, the clinical scenario. So it's not a rule from above, you need to have this chemotherapy for this situation, but more engaging the idea of all of these things are important. We need to have a discussion to make sure that we're valuing them all based on a patient-centered frame of reference. The idea of price transparency is so novel and good. Ultimately, I am confident that price transparency will improve costs for patients. Unfortunately, it is not something that is being realized currently. There was a rule at January 1st of this year that all hospitals had to post their payer negotiated rates, which is essentially what each hospital negotiates with each insurance to pay for specific services. In our own work, this is actually just got accepted. We looked at cancer centers and specifically evaluated their compliance to the idea of price transparency. Again, unsurprisingly, very poorly compliant. About 80% of centers were not compliant. And then for centers that actually did have pricing available for example, a colonoscopy with tumor removal or a single treatment with radiation, we found that the prices were incredibly variable. So for example, I'll highlight in the lower that there was a center charging up to $37,000 for a single treatment with radiation, and the lowest cost was $300. So we're talking about an incredible variation between centers and sometimes within cancer centers for what they're actually paying what they're charging insurance companies for cancer treatments. And ultimately, we know that this affects patients, right? Because even if your co-insurance copayment is 10%, that makes a big difference if it's $3,000 versus $37,000. I want to highlight the idea that financial navigation doesn't have to necessarily be in person. So this was an amazing study, again, out of the Safar group at Duke, looking at financial navigation through an app. What they found is that their app-based financial navigation was able to improve the percentage of people who applied for and received financial assistance. So again, the idea that maybe there are things that we don't need, people in front of people for, but we can use an app to facilitate applications for financial assistance. And then I want to plug the idea that we should be doing more to identify those who are at high risk before they actually experience financial toxicity. So again, anticipatory versus reactionary. We know that this is from our own work, but it's consistent with prior work, which is there are certain disease types that are more likely to have financial toxicity. So for this study of gynecological cancers, women with cervical cancer were more likely. Younger patients were more likely to suffer financial toxicity, patients with more advanced diseases, and unfortunately, racial and ethnic minorities are more likely to have problems with financial toxicity. We also know that insurance matters. So for example, commercial insurance, obviously self-pay or uninsured patients are going to have more problem. And then anyone other than who are married, so single, divorced, separated, those patients are more likely. What we actually did was look to see, well, are there things that providers are doing that actually increase financial toxicity? So for example, participating in a clinical trial, those patients were more likely to have a problem. People who had more inpatient days, people who had more imaging studies, people who had more visits, they were much more likely to have problems with financial toxicity. And ultimately, when you put this all together, even when you control for advanced stage and disease type, things that, for example, are within our own control are actually, driving financial toxicity for some patients. So for example, more imaging studies, more clinic visits. So maybe there is some clue there of what we could potentially do in terms of on the provider level. I'm running out of time, so I'm going to skip a couple slides. Don't mind me. I wanted to highlight the fact that we can diagnose financial toxicity. There are validated measures, and it is something that we should be doing in our clinic, even if it's just a simple screening test. So this is the NCCN problem list. It's yes/no questions that people can answer in the waiting room. One of them is, are you having problems with finances and insurance? There is a validated score for financial toxicity, which is scored on a Likert scale. It takes about 5 minutes for your patients to do, and it associates financial toxicity with quality of life decreases. And then you should think about maybe screening for other things other than, just in terms of burden of cost, but, are people actually making compromises related to medications? Is their income not enough to actually meet their needs? Have they had to use their savings, or have they had to take out loans or go into debt related to cancer treatment? So this is a pilot that we're initiating to try to systematically screen our patients for financial burden. I'll just end in terms of, softening the impact. So how do we decrease ongoing effects of financial toxicity? And it really is, I'll be honest, just having a conversation can do a world of good for patients. This is not the end all be all, but we know that patients really do care about costs. They want to talk to their doctors about cost in some capacity. Sadly, only the minority have talked to their doctor about their costs. And it matters because it can help. I mean, it doesn't help every single person. It doesn't reduce everyone's costs to zero. I wish it did. But we know that from our research that, for people who discuss their costs, it can help reduce them. And it can reduce them in ways that are not necessarily changing their actual cancer treatment. So a key thing here is, again, referring to appropriate financial assistance, sometimes appealing to insurance, sometimes switching from Anusol, the $400 suppository, to something over the counter, like Preparation H. So again, some simple solutions sometimes to some big costs for patients. I want to highlight the idea that we should be empowering the clinical team to actually ask questions and then to respond to them appropriately. So again, just to highlight an MSK pilot, we put in place an order that you can refer someone directly to Patient Financial Services, which is PFS. And you can tell us exactly what's wrong so that we can, number one, track the problems that people have, but also that the benefit that they're receiving from our services. Because the last thing I want to do as a provider is to start the conversation and then not be able to help someone. So wrapping up, I know that there are, primary prevention, the idea of education, navigation, eliminating low value care. We can do secondary prevention, we can diagnose financial toxicity, we need to screen early, we need to screen often. In tertiary prevention, we can normalize cost conversations, we can get people the help that they need, because one thing that our research at MSK highlighted is that we actually have resources that patients are not getting. And it's a real disconnect between getting people in need the help that they need. So we know that financial toxicity mitigation is possible, but unfortunately it's really growing in the United States. And that's important because cancer outcomes are at risk. I want to highlight the fact that we have a top-down approach from financial toxicity. We spend a lot of time at the bottom of the pyramid. And ultimately, like any public health emergency, you want to flip the pyramid. So we want to spend much more time and effort on prevention than we do on treatment, to be honest. The same thing is true for COVID. And so, the flipping the pyramid is really paramount when we think about financial toxicity. All right, so I will end there with 12 minutes for questions. I apologize for my rapid voice. Just wanted to get through as many slides as possible.
Thank you so much, Dr. Chino. That was a really informative and incredible presentation. So now I will hand it over to our director, Beth Brenner, to facilitate a Q&A session. So feel free to drop questions in the chat box, or feel free to come off of mute and ask them yourself.
Great, thank you, Alex. And thank you, Dr. Chino. That was a wonderful presentation. And we already have messages in the chat that are saying, thank you so much for the presentation. And we have some questions. So if you don't mind, I'll just start off with first, Dr. LeConte wanted to just say wonderful talk and had a question for you or any other member of the panel. Do you know how many people in the US spend time caregiving for patients with cancer? And how does this impact the caregiver?
So I can speak to this personally as a cancer caregiver, that it impacts you very poorly. So personally had huge medical debt related to my husband's cancer treatment. It impacted my career. It impacted my mental health. It impacted my actual physical health. And those effects have been really lasting. And cancer caregivers are really an unknown resource in the United States. We routinely rely on cancer caregivers to provide the best care for our patients, and they're really unpaid and they're unrecognized. There has been some legislation recently to try to actually allow patients, family members, to receive some compensation related to the unpaid care that they're giving to their family members. To my knowledge, that is still something that is in the works, but I would welcome it, because we are asking families to sacrifice significantly in order to provide the best care for their family, and we just expect it, and it's not right. And it particularly hurts people who do not have family members who can take time off of work, and it really creates an additional strain on the entire family unit.
Great, thank you. Next question was asking if you could speak to how telemedicine may affect financial burdens. And if you've heard of copay might be higher, but the travel cost might be lower, kind of if it's all a wash, or should we be pushing for telemedicine as a cost containment strategy as well?
So we have some work just out of MSK that was published in JNCCN earlier this year, specifically looking at patients who are on treatment with radiation, because I'm a radiation oncologist. And what we found is that telemedicine really did lower their costs. And so the majority of patients said, yeah, it was cheaper to have a visit from telemedicine, even if it was just the consult, because as you know, radiation is a daily treatment that you have to go in for. But even just saving them time and money away from work for the consult itself, it really was a benefit. So one of the ways of actualizing the only maybe positive change from COVID is to thinking about making it more permanent in terms of reimbursement for telemedicine. I have not actually heard that that some people's copays were a little bit more expensive, but I'd be fascinated to know who that was specifically affecting, because it should be just a standard copay. But yeah, if we can really make the reimbursement for telemedicine permanent, I think it could really help a lot of patients in rural areas, because it's just a lot of driving, and it's paying for parking and time away from work. That's a huge thing.
Great, thank you. We have a question from a pathologist that was asking for your recommendations for those that are in the laboratory and how they could help reduce financial toxicity. So as we try to minimize costs, but some workup is very important for getting a specific diagnosis or qualifying the patient for targeted therapy. So any thoughts or recommendations?
Yeah, it's really interesting. Because cancer care is so multidisciplinary, I mean, it takes all types of people to provide the optimal care for any cancer patient. You can really think about each step of the way, how each individual, from, the pathologist to the radiologist to, the medical oncologist, can really have an important role to play in cost containment and affordability. And I think, one thing that is kind of currently up for debate is whether or not we should do, for example, next generation sequencing on every single person, or for example, complex genetic testing for every single person to try to get them to, to the optimal tailored precision medicine that they could potentially benefit from. Or if we're spreading the net too wide, are we looking for things where the ultimate benefit is going to be in such a small percentage of people that we're going to then be translating a high cost for tests to hundreds of thousands of people when it's only going to benefit 5? There's some really great cost-effective analysis looking at this concern, and I do think it's something that we should think about every time we order a test, or for pathologists, if you run a specific different assay, what is the expectation that we will get a positive, and is there something that we can manifest that actually will help? Because one thing I've noticed, for example, with some of so at MSK, we do IMPACT, which is complex genetic sequencing on all tumors as part of a clinical trial. So it does not get billed to insurances, or it does not get billed to the patient. But we often find mutations that are interesting to find, and they may ultimately help patients in 20 or 30 years. But it's not a targetable mutation that will benefit the patient to find. And it often leaves patients very frustrated to say, well, you found this, well, how is this going to change our management? And then I have to say, it doesn't actually, And so again, it improves maybe the wealth of knowledge for science, but it may not help that patient. And if those tests cost money, then we really have to think about the therapeutic ratio for them.
Thank you, Dr. Chino. You have one now that says, first, your presentation was excellent, but then also asks, can financial toxicity be defined as a type of grief?
It is for me. I think it's interesting. There are different ways of categorizing financial toxicity. There's objective financial toxicity. There's subjective financial toxicity. There are direct costs, there are indirect costs. But again, I think that emotional burden of high costs and the stress and anxiety related to financial burden, I think is incredibly high. And then ultimately things like, the complex nature of grief and what is left, for example, to caregivers when they're left not only, with incredibly high, emotional distress from their loved one having died, again, so I'm a widow, but then also with this incredible financial burden. I had debt collectors calling me literally at my husband's funeral. It is just, it is indescribable in terms of thinking like these are common concerns for some of our patients, and it's not every patient, but even if our treatments are causing this level of financial toxicity for a quarter of patients, which is about what I would peg it at, and some variability, that's too much. It's too much in the United States. We cannot be leaders in the world while leaving so many of our own population in the dust.
Well, thank you, Dr. Chino, and thank you, again, for sharing your personal story. That's, it brings it home not only as, healthcare professionals, but really as the one that we are trying to be advocates for and trying to make change. So we have a question as a physician. You are trained to diagnose and treat disease, but now you've been put in the position where you also need to help your patients consider financial burdens. And in cases where you may not have sufficient information of insurance coverage or co-pays, and helping make that logical decision. Do you have any recommendations on how to reduce that burden on the medical professionals and allow them kind of to do their primary work, but still be supportive of this decision-making process with patients?
I think each provider is going to come to this in sort of a different way. And there's certainly people that are like, I do not have the time, I do not have the wherewithal, and I've never received any education to try to help with solutions. But I think ultimately, if you change your framework to this is a group effort, we have providers, we have obviously our incredible oncology nurses, we have oncology social workers, we have people within patient financial services. And the idea is to rally support around patients so that they can get the optimal outcome. Just as, again, if you had someone with, radiation pneumonitis, so a problem that, a side effect related to radiation treatment. You may, ultimately need to put them on a prescription. You may need to refer them to physical therapy. You may actually need a multi-factor, multiple potential solutions that could actually help them, deal with that side effect. So I do think that, it is not a unique burden on providers. We really need to think about it on rallying the resources. In terms of just thinking, for yourself, it's just, you are not going to be able to provide the best care for the patients if they ultimately, I can design the best, most innovative SBRT radiation treatment for a lung tumor that will cure their early stage lung cancer. But if that patient doesn't show up for treatment, it was literally of zero benefit to them. So ultimately, we need to provide the best care, and we need to work with patients to figure out, how do I actually get that in you, because it's not one size fits all. Cancer diagnosis and treatment is not one size fits all, and financial toxicity solutions are not one size fits all.
Thank you. We have, I think there's a couple maybe around advocacy and just understanding. So one is that, do you know if there are any studies that compare financial toxicity in countries with universal health care and in the US? And then after that, if you have any thoughts or recommendations on how we engage policymakers in this discussion and issues around financial toxicity.
So there is financial toxicities in other countries, specifically in countries with nationalized healthcare. For some of those countries, it just manifests in a different way, and it maybe is not as extreme as within the United States. So for example, Germany as a nation has I believe it's 6 weeks, 100% paid leave for sickness, and that is guaranteed. And then if your illness lasts more than 6 weeks where you're unable to work, you actually can get an additional 78 weeks of paid leave at 70% of your salary. So that's obviously not something that I can decide is going to be a healthcare policy, but that would be a big policy initiative to just improve sick leave in the United States and to try to improve it. However, even within Germany, even with those assistance, there's still problems with people not having, the ability to pay for medications. Out-of-pocket expenses are still high for them. Travel and parking is still an expense for them. Other nationalized healthcare systems will say that the burden of travel is probably the largest driver of financial toxicity. So specifically thinking about studies done in Canada, which is a large country where cancer care is, what's the word I'm looking for? Centralized. So people may be driving miles and miles and miles in order to receive their care. So the burden does exist in other countries. I do think it's milder, but it's still a problem. And then the second question, I apologize, was about policy. What was just talked too long already.
No, just how to engage the policymakers.
Yeah.
So what we're seeing maybe in other places, or how do we begin the conversation with policymakers around the issue?
So what I always say, and again, maybe this is just my own selfish way of thinking of it, because I do have the story and I have the data, but you do have to root any evidence-based conversation in an anecdote, because people do respond to a story, they respond to personal narrative, they respond to tragedy and grief. And so when I tell the story of financial toxicity, I always root it in my own personal experience, and that is how you change minds. So when you talk to elected officials, when you talk about policymakers, it's about telling why this matters to patients, and then backing it up with the data. So mirroring, again, the anecdote with the data, because you need both. And it's really about, sometimes it's literally like driving, having enough momentum behind your words to drive policy change has been, sharing stories, getting national news, as in part of the conversation. So for example, the incredible discussion about high parking costs for cancer patients has really driven additional conversations at many cancer centers to think about, how do we change how we provide care? How do we get free parking for our patients? Because at a certain point, you're just nickel and diming your patients, right? Charging $20 for parking, charging $30 for parking. It's insulting. And there's got to be a better solution. Again, that's an example using parking, but each time you have to find someone who's willing to tell their story. You need to pair it with data, and that is how you make a compelling argument.
Dr. Chino, we have one final question. If you have one more minute maybe to address it, it's around clinical trials and how that might increase the financial burden for patients.
Yeah, so I think, anyone involved in a clinical trial, if you enroll people in clinical trials, if you've participated in yourself, or if you've designed them, that clinical trials typically do actually increase the burden on patients in terms of coming in for visits. There may be specific requirements in terms of tests within a framework where I literally have someone on clinical trial now. I would not normally see her 6 weeks after her treatment, but it's part of the clinical trial. So that's going to be an extra visit for her. It's going to be an extra copay for her. It is within the standard of care. So it's not crazy, but it is not something I would normally do. I would not necessarily have reordered lab work for some people in clinical trials, but it was required from the clinical trial. So there are additional burdens on patients. There are just the travel burden itself to qualify for a clinical trial. Clinical trials are only given at certain institutions typically. They are not necessarily available at every cancer center. Lazarex is actually a great nonprofit that can help provide financial assistance for people to participate in clinical trials, by the way. But one of the benefits of COVID was that we actually have changed some of our regulatory concerns regarding clinical trials. And that has enabled people in clinical trials to, for example, have a telehealth visit that could save them a trip for something that they can have their labs closer to home, even at maybe at a lab that's in network or imaging that is in network, and then just send along the results so that it is safer for them in a global pandemic, but it also saves them money. So that is another potential benefit of how we have reconfigured how we deliver care under the pandemic. But I think that all of those things contribute to increased burden, and I think that we've identified some potential solutions.
Great. Thank you so much, Dr. Chino, for your presentation and your time today and really sharing with your heart and your personal story. So I'm going to turn it back over to Alex to close us out. So thank you.
Everybody, just to close us out, I am going to launch a poll real quick. If you would mind answering that for us, we'd really appreciate it. It helps inform our future webinars. And while that poll is going, we just wanted to quickly highlight too how today's topic ties back to our Wisconsin Cancer Plan. It ties in very closely with Chapter 4 treatments with several of our priorities. So if you'd like to dig into that more and see some of the action steps that you can take to directly address some of the things on the screen and that we talked about today, you can find that directly on our website. And again, here's just a plug for our financial toxicity issue brief. If you'd like to learn more, you can definitely check that out. And then also, we would love to see you all for our September webinar. It is going to be on Share the Care, Cancer Issues in Wisconsin's Native Communities. So that will take place September 9th from 10 to 11:30.
I just want to plug in for the issue brief. I read it. I was really impressed with the level of the quality that was put into it in terms of how it flows and the education related in it. It was just top notch. I was really impressed.
Thanks, Dr. Chino. I'm sure that Amy and Alexandria really appreciate that coming from you. Again, thank you all so much for attending today. We will be sending out a recording of this presentation